Okay, we're going to get started now, everyone. Thanks so much for being here and for your interest in our MHTTC School Mental Health Curriculum Always and Now Learning Series. This is session 4, screening. Hopefully you've seen this slide and you're comfortable with Zoom at this point. How we're using it today is that you're all muted. And if you have any questions about the tech or the audio or need help with anything, we'll also be putting links for how you'll access your certificate and how we'll follow up with you after. All of that will go in the chat, and we welcome you to introduce yourselves, put your name, where you're from in the chat as well. And for questions and resources, those will go in the Q&A pod, and those will be the questions that we'll get to at the end too for our panelists. So that we also have captions available for today for those who would like to disable or enable them. Click on the CC icon at the bottom of your Zoom platform and select the arrow for options to display or hide those captions. So I'm Stephanie Winfield. I'm the school mental health lead with the Mountain Plains MHTTC, and I'm so excited to be able to moderate today's session with you. Thanks so much for joining session 4 of our 8-part series. We are halfway through of this school mental health curriculum Always and Now series. A few housekeeping items. We're going to launch a poll for you momentarily, and we'd love to hear a little bit more about you and learn from you as well. So please complete that as I go over these housekeeping items. So as I'm sure many of you are now familiar with Zoom, we just want to review a few things so that you're comfortable with how we're using it today. As I've already said, for best audio quality for today, we've muted all the mics and all the participants except for our speakers. If you have any audio or technical issues during the session, the chat box is open for you to communicate with our team so they can assist you. If you have a link to resources you'd like to share with the other attendees or questions for our presenters, please enter those in the Q&A pod. We have team members who are monitoring the Q&A pod, and they'll ensure the facilitators receive your questions. To open the Q&A pod, hover your cursor over the Zoom toolbar at the bottom of your window and click on the Q&A function. We've scheduled ample time for our Q&A with our guests, our panelists, towards the end of the meeting, but feel free to enter your question at any time. We've made every attempt to make today's presentation secure. If we need to end the presentation unexpectedly, we'll follow up using your registration information. You'll receive an email following the presentation on how to access a certificate for attendance for today, as well as information on the recording and the slide deck. And they'll be posted on our website within a few days. And a reminder for that captions are available for those who would like to disable or enable them with the CC button at the bottom of your Zoom platform. And please follow us on social media if you don't already. So our MHTTC network, the Mental Health Technology Transfer Center, also known as the MHTTCs, we're a network funded by the Substance Abuse and Mental Health Services Administration, SAMHSA. And we include 10 regional centers, a National American Indian and Alaska Native Center, a National Hispanic and Latino Center, and a network coordinating office. Our collaborative efforts include support resource development, dissemination, training and technical assistance, and workforce development for the mental health field. And if you have not already connected with your regional center, we suggest that you find them and be in touch with them and learn all of the other opportunities that they have available. A disclaimer that this presentation was prepared for the MHTTC network under cooperative agreement from the Substance Abuse and Mental Health Services Administration, SAMHSA, and the opinions expressed in this session are the views of our moderators and panelists and do not reflect the official position of the Department of Health and Human Services or SAMHSA. Part of receiving our funding from SAMHSA was we're required to submit data related to the quality of our events. And so we very much ask that you complete this really brief evaluation at the end of our session today. When you pop out of your browser window, the evaluation will show up and it'll just take you a few minutes, and it means a lot to us. So we really do appreciate you taking the time to do that. And don't forget to join our regional breakout sessions at the end of this live session. These sessions are intended to provide an opportunity for you, our participants, to ask questions about the context we'll cover today, and gives you time to discuss and apply today's learning in an informal, moderated discussion with our staff, contextualized for your specific region. So at the end of, towards the end of our session today, you'll see the links for your regional session, and it's 30 minutes that we hope that you'll join us, and our speakers will be joining those sessions today as well. So thanks for your attention. We're going to get started with our content. It looks like about half of us, a little more than half, were able to watch the video. And we provide that video so that you have a better idea of what we're going to be talking about today. And we're lucky also that we'll get an overview of that for those who didn't have the opportunity. And it looks like our mastery of screening is kind of in the middle. We have a majority of people who feel they have some experience, and then we're kind of all across the board pretty evenly displayed. So hopefully this overview and then our session today will help you all feel a little bit more informed and prepared. So as you know, this is an 8-part series, and we are at number 4, midway through. Uses the National School Mental Health Curriculum, guidance and best practices for state districts and schools. The curriculum was developed by our network in partnership with the National Center for School Mental Health in 2019. And it's intended to help states, districts, and schools advance comprehensive school mental health and engage in a planning process for implementation, and includes a trainer and participant manual, 8 sets of slide decks for each module representing the core features of comprehensive school mental health, as well as many, many additional resources. Today's live session will consist of a discussion with a small panel of educators and mental health leaders who will provide an always and now application of the curriculum. While we know that this school mental health curriculum is a great resource to utilize in schools settings all the time, we know that it's especially relevant in the current context with the COVID-19 pandemic and its impact on the provision of school mental health services and education in general. So our panelists will share with us their experience using the curriculum and then the innovative ideas for implementing in this current context. So we hope that you did watch the pre-session video. We know about half of you did. That the video was really to help everyone familiarize themselves with the curriculum material. But if you didn't have the opportunity to watch it, you are in luck, because we have Jill Bonnekamp with us today, who will serve as one of our panelists and give us an overview of the session. So Dr. Bonnekamp is an assistant professor and core faculty at the National Center for School Mental Health within the Division of Child and Adolescent Psychiatry at the University of Maryland School of Medicine. And she has extensive experience in school mental health, research policy, and clinical practice at the local and state levels. So I'm excited to pass it on to you, Jill. Thanks so much for being with us today.
Absolutely. Thank you, Stephanie. Hi, everyone. Thank you to all of you for being here today. It was really exciting to see folks from across the country as you put your information in the chat, from Florida to Texas to Seattle and Maine and across the United States. So I am pleased to share an overview and show some of the materials that are in Module 4 of the National School Mental Health Curriculum, which focuses on screening. And so I'm going to walk you through what's included in the curriculum and everything you need to know to begin to think about how to engage your community, all the way down to the specifics about every step of what you need to do when you're thinking about school mental health screening, and examples from districts. And as you can see this is our agenda that walks through what is included in the curriculum. So one of the first things we do in the curriculum is define what we mean by school mental health screening. And a critical piece here is that this is to identify students at risk for mental health concerns, and that this is not just for students who are already displaying mental health concerns, but really to think about how are we doing this in a systematic way to make sure we're identifying any students that may be at risk. And within the curriculum, a really critical slide here is a number of bullet points, and beyond the bullet points included in the curriculum are more details about making the case for screening and thinking about screening. So I can imagine that many of the folks here that are attending this session already are strong supporters of screening, and this is something that perhaps you're doing in your school community or you want to bring to your school community. But we know that there are a number of folks who have concerns about it and that we want to be really intentional about it. And so there's a number of resources here around just why it's so critical that we're screening for mental health concerns and doing this, excuse me, in a data-driven way. So a number of resources why it's always important that we're thinking about mental health screening. And I want to share some additional thoughts for this now, why it's so critical that we're screening for mental health concerns in response to COVID. And so I want to take a little bit of time to look at these numbers. We know that mental health concerns have increased. And so really we can't not screen. When we look at these numbers, we see that every other student is reporting moderate to extreme concerns about mental health. And so we know that we can't serve that many students through Tier 3, and we really need to be using a data-driven approach to prioritize students who are at the highest risk. So if we look further down these statistics, we see that 25% of high school students are saying that they know someone who has had suicidal thoughts. And so we know that that risk is high, and that I hear many folks in school districts, and I'm sure folks are shaking their heads as well, that they don't have enough clinicians, or that they want to be thoughtful around how to make sure they can provide services for youth who are most at risk. And if we're not screening, then we may be missing some of those students, and we may not be prioritizing the students that need these resources the most. And so this is just additional information for you to make the case to bring this back to your school community and to really be thinking about how to make this happen. And so within the curriculum, you'll see that there are screening quality indicators and also screening best practices. And then within the curriculum, probably one of the most important things that we'll talk about is that, we know there's this important need and this great need to do mental health screening. But it's very critical that this does not mean starting by screening the entire district tomorrow or next week or next month or next year, and that school districts, and you'll hear from our panelists today, that have had the most success and have done this in a way that has really supported students without risk, is by starting small and thinking about one student in one school, piloting your process. And there are many resources within the curriculum that really talk through that and talk through how to do that and share examples of how districts have done that. So the curriculum walks through a screening action step process and includes very specific examples and tips from the field for each of these steps. And I'll go through each of these steps today and just show you an example of some of the things that's included in the curriculum. We won't spend time today sort of going through each detail, but just a sample so you can see wherever you are in your process, whether you're starting at this building a foundation stage, or you're really already to the point where you're thinking about selecting a measure. There's a wealth of information within the curriculum to help you at every step of the process. So these next two slides that I'm going to talk about are probably your two most important steps in your screening process. And spending a good amount of time on building a foundation and generating engagement and support is really critical to making sure that you're having a successful screening process. And so you really want to think about engaging all members of the school community. You can start this by thinking about focus groups and thinking about questions about the benefits of screening, challenges and concerns related to screening that your school community brings up. think through consent and privacy considerations, and thoughts you may have for screening, implementation, scoring, and referral. And you also want to think, really closely about how your screening goals fit with other initiatives in your district, and how this is critical to the goals of your superintendent, of your school community, and what you're prioritizing for your district, and making sure that screening is helping to support that and helping to support students. So this is the second critical slide, is that when we're thinking about building our foundation and engaging our school community, that we're thinking about engaging all members of our school community, and that we're being really intentional about thinking and making sure that we have representation from all voices, that we're thinking about how do we be culturally sensitive and really intentional in our screening processes. And that starts at the very beginning of making sure that when we're talking about screening and what this might mean, that we're receiving input from all families represented in our school community. So there's great resources in the curriculum talking through those key important steps. And I encourage you, as you're getting started in this work and continuing in screening, to really make sure you're being thoughtful around those two pieces. And then another piece that's really critical is thinking about data as a way to build a foundation. So we've seen districts that as they seek support for school mental health screening, that it can be helpful to turn to data. So for example, one school district used data from their screening pilot to demonstrate the value of screening. And again, this is important information that you can get from the curriculum for you to think about how this might work in your school district to help to make the case and to really help you to see, sort of why this is supportive, and help others in your school community to see why this is a critical step. And so throughout the curriculum, we go through each of these action steps. I'll move more quickly through these next slides, but I just want to show you some of the additional resources that are included. For example, on the next slide, there's additional resources around clarifying goals. And on the next slide, you'll see some examples around identifying resources and logistics. We have a specific slide around staffing, and then also one around thinking about logistics for data infrastructure. Moving on to thinking about selecting an appropriate screening tool. There are resources, and everything within this curriculum is free. So all of the resources we'll point to are free resource here around selecting an appropriate screening tool. There's quite a bit of discussion and resources in the curriculum around thinking about consent and assent procedures. And as you can see here, there's a table around that. We also have samples of consent and assent that other school districts have used and given permission for us to share, and other just logistics around student assent and consent procedures. You'll also see that there are a number of resources around developing your administration processes, and importantly, developing follow-up processes. So making sure that you're being really thoughtful around, if there is a student that's identified at high risk, how do you make sure you have resources in place and staffing in place to do follow-up? Also points to the School Mental Health Quality Guide, which is another great resource that's within the curriculum that has additional tools and suggestions and tips from the field around school mental health screening. And we know that this can be a big undertaking. We hear from school districts across the country that there are barriers related to screening. And so there are additional strategies here and things to think about. And we are thrilled that we'll be able to hear from our panelists about how they've also addressed barriers and used the curriculum and resources within to think through and to be addressing. And of course, real district examples. This is an example of a district that was able to start small with screening a few students in one school, and over the course of the school year, through an iterative process, was able to expand to implementation to a large-scale online screening in a high school. And again, sort of talking through this, both in the very specifics of things you can use, and then also sharing how other districts have been able to do this. And then there's a list of resources within the curriculum for you to be able to access additional resources around screening. And so before I turn it back over to to Stephanie and our panelists, I just want to highlight some of these key takeaways that are included in the curriculum. And as we're thinking about mental health screening, always, but especially now, we know that mental health screening is critical for efficient resource allocation. So with this high level of mental health concerns, we can't afford to not screen students. We know that we need to prioritize our resources and make sure we're being preventative when we're thinking about mental health crisis incidents. And when we're thinking about key action steps, we don't have to start with screening the entire district. We want to start small, work with a stakeholder group that's inclusive, and start to develop our process. And I just want to thank everyone for joining us today. Encourage you to dive into the curriculum. There are a number of resources in there for wherever you are in this step. And glad to turn it back over to Stephanie and to hear from our panelists who are doing this practice in their districts. Thanks so much, everyone.
Thanks so much, Jill. We really appreciate that overview. There's so much to this module. You gave us a really good overview, but we encourage you to dig into this module and see for yourselves how many resources and how much great information is in there. So I'm really excited to move into our panel presentation and introduce our panelists for today. We have Todd Wester, who's the Director of Curriculum and Multi-Tiered Systems of Support in School-Based Mental Health and Behavioral Health in Livingston, Montana Public Schools. And he's also a member of the Montana Student Wellness Advisory Committee. And we have Joni Spelt, who's a professor of school psychology at the University of Florida. Dr. Spelt's research focuses on the prevention and intervention of emotional and behavioral concerns for youth and schools. So thanks so much, both of you, for being with us. And I invite you each to tell us a little bit more about yourselves, your roles, and your work on school mental health screening, how it plays out in your work. So Todd, if you would like to go first. Thanks so much, both of you.
Yeah, thank you. Well, I have this title in our school district. I'm the Director of School-Based Mental and Behavioral Health. That's something that's very new to Montana districts, but something that we acknowledged was necessary because we had a large influx of students with struggling with mental health issues, and we needed some people to be on that work. So I'm one of those people. I have been lucky to be part of the MHTTC project from early on and to get to experience the rollout of the school mental health curriculum. So look forward to sharing with you.
Thanks, Todd. Like Stephanie said, my name is Joni Splat, and I'm an assistant professor of school psychology at the University of Florida. And I come to this work more on the practice side, actually. So in my early career, was lucky enough to kind of work alongside, support, and learn alongside a couple of districts in the Southeast who were, on the front edges of screening and trying to figure out how to do it and the advantages of doing it in their school districts. And that really just led to a lot of kind of implementation type of research questions for me. So have launched into more working alongside school districts to not only support them, but also kind of evaluate how some of these implementation decisions play out. How do they overcome these challenges? What works best? How can they be most efficient in that? And so have tried to kind of share the things that they've learned working and not working. So I'm happy to be here, part of that today.
Great, we're happy to have you both with us today. So I'd love for you to share some of the challenges that you've encountered around screening. So we'll have Todd go first.
Yeah, thanks, Stephanie. So Jill hit the nail on the head. It's important to start small, and that's been very difficult for me personally and for us to do as a community. It was remarkably difficult not to want to go too fast with deployment of the screening program and to not want to mandate that every student take the screening rather than allow parents to opt in at first. We followed the steps of the module to a T, but the more that a group of us became aware of the benefit and the purpose of screening, the more we began to feel as if life literally hangs in the balance, and that we may lose students that we could have saved while we, slowly build trust in our community around the screening project. It's really hard. It's been difficult for all of us who feel like we really want to see this, fully operating and want to see all of our 700 grades 6 through 12 students being screened, starting tomorrow. But the alternative to moving slowly is to move too fast and lose community trust and potentially to be unable to revisit the idea for a long time. We've seen projects in our community fail in that way in the past. And so even though it's a little anguishing, it's really important to really start with that one student and move slowly. And even though we've done health and academic screenings for years, we were brand new to the concept of social and emotional screening. And so we really had to do the who, what, when, where, why, and how. And I think the why is the biggest question that I face from members of our community who are unfamiliar with our screening program. Even in a community where it's fairly well known that we have high rates of youth risk behavior and anxiety, depression, and suicidality, still there are a lot of people who wonder if it's really the proper privilege and responsibility of the district to do mental health screening. And a lot of that stems from a strong sense in the community among many that there is iatrogenic risk. That is, that asking questions around depression, anxiety, and suicidality will actually cause it. But, we're having some success with helping our community to understand that while screening can detect suicide, anxiety, and depression, it's not so likely to cause it. And so we've had some success, again, by moving slowly in helping families to understand and to know a little bit more about what we know about the iatrogenic risk. There are a lot of families who worry that screening is going to inevitably lead to sorting and tracking. And that is, my child through this screening will be grouped with a group of students and then sort of track that way through school. We really work hard to dispel that notion in all of our screening, that really the reason that we're screening is so that we can get kids the help they need as rapidly as we can get it, so that we can catch them up or help them to improve in whatever ways they need to, and so that we can kind of customize the treatment for each student. We had some questions around who should do the work of first leading the project, seeing it through to fruition. You really need somebody, I think, to do that, and it's hard to find that person on limited resources in a school district, but we were lucky that we were able to take a little of my time for me to be able to do that. And you also will have the question of who needs to be involved in the development of the screening program and how you get them there. We've been lucky in that because of our community-wide data, we do have a lot of professionals in the schools, mental health, healthcare, philanthropic partners, our several families and students and state agencies who have been willing to join a committee to do this work to identify the screener. Then who's going to administer the screener is one of the most critical questions, I think, and it's hard to figure that out. Everybody's time is already booked solid, typically in a school system. The way our solution so far has been to have our school nurses do this so that it looks something like a typical health screening to our families, and also because our nurses have a good sense of how to do health screening. And so many more challenges will you face, but I think those are some of the top ones that you'll encounter as you embark on a screening project.
Yeah, and I think that one thing I was going to add on top of that was thinking around a lot of times challenges I get from districts is around funding and having financial means of adopting a screener, with so many of them costing money. And so there's definitely the tendency I see among districts of trying to go towards something that's free or very low cost. And I certainly have some districts that have had some examples with that, but it also, and some positive examples, good work from that. It also, I always use kind of the metaphor of like, you get what you pay for. And, you know, I believe that with my haircuts. I pay a little bit more than my partner does, my male partner, for his haircuts. You get what you pay for, kind of thing. So it sometimes is worth putting some money into. And I also, the districts I've seen go towards a free measure that is free, they end up putting personnel resources. So it takes a heavier load on their IT people, on their legal team, and figuring out who has access and rights and responsibility, and making sure that that's layered into the system. So I generally find districts, you're either going to put the resources into buying, so you have money to pay for the screener, or you're going to put it into FTE. So either way, it's going to cost something to adopt and implement. It's just kind of where your resources are available to, you know, and free.
Thank you both so much for that one. I bet our participants can relate to many of the struggles that you've mentioned and the obstacles. And so now I'd love for you both to share a little bit about the positive outcomes and successful results that have come from your screening efforts. Todd, how about you go first?
Well, on this side, sure. Yeah, on this side, it just feels so good to have the screening underway. You know, there's that, I think, a great sense of anticipation, and you know, there's some nervousness around getting the thing launched. But once we started working with our social and emotional learning screener, you know, in some ways it wasn't that different from doing academic screenings or from doing health screenings. It was kind of like a hybrid in that, you know, there's sort of the health component, and we're billing it as a health screener, but also it's informing what our social and emotional learning programming is going to be and how effective it is. So, you know, once we got it started, it felt familiar, it felt good, and you know, the dialogue started happening around, okay, what adjustment do we need to make here or there in terms of scheduling or outreach to families or things like that. But it didn't end up being so different from what we are used to doing. And you know, the greatest benefit, of course, is in discovering those students that we would not have otherwise known about who are struggling with suicidality, also anxiety and depression, and connecting those students and their families with treatment. You know, we've all said, I guess our mantra has been, if we discover even one student who we didn't know was imminently suicidal and we connect them with life-saving treatment, it's worth everything that we did. A really serendipitous thing has happened. We had a couple of researchers land in Paradise Valley, which is very near Livingston, Montana, who have a strong background in research in youth suicidality. And one of these people had formed a group that was developing electronic patient-reported outcome surveys, essentially take validated screeners, but put them in a branching survey electronic format. And that has given us a small Montana district an opportunity to work with some people who really know a lot about this, and to kind of both contribute to a project in which we're trying to develop a screener that could work in schools statewide and across the nation that, you know, fits what schools need, but also that meets the science of screening in the social and emotional realm. So that's been a really fantastic thing to be part of, and we've been lucky to have them at the outset work with us pro bono, but they're working to try to develop a cost-effective solution for schools. It's very fun to be part of that project, and it feels productive. And you know, we've gotten some good press here recently in local and statewide news. Our Yellowstone Public Radio station carried a spot just last week, and I only mention that because every bit of that we get seems to make it seem more mainstream what we're doing. And you know, I think it reduces the stigma around screening for social and emotional issues. And you know, we're not getting any, crossing my fingers, but we're not getting any bad press so far. We've gotten you know, really some good attention. And Joni?
Yes. We have some preliminary positive outcomes I think I can share. In a randomized trial, we did show an increase, and it's preliminary, getting ready to be submitted for peer review, an increase in elementary school students receiving social emotional behavioral interventions in schools that did screening versus those relying on more traditional, typical teacher or parent referral practices. So definitely have some preliminary evidence supporting kind of the hypothesized rationale really driving this movement towards screening, which I'm glad to see. And I think we've also, in that trial and in some of my other work, really tried to kind of think about how can we even more enhance and increase that linkage. It's probably it's good and it's better than teacher referral, but probably still not 100% and adequate. And so really working in some additional work we're doing now of trying to use, and I can talk, probably at length about it, so I'll be brief, but trying to use, screening more as a needs assessment at a system level. So moving beyond that kind of individual work and use it as a needs assessment to inform kind of how we allocate resources in the service delivery model and what services we're offering where to whom. So seeing what the needs are at what grade levels and what student populations can really help align the services we have and build capacity there to better meet needs so that we're ready for whatever is identified once we do screening.
Thank you, and thanks for bringing it back to why we actually do this. I think we sometimes lose sight of that piece of it. So
yeah,
we really do this to support the students, and if we have one student, then it's made a huge difference for that student. So tell us a little bit about what has changed and how your school does screening now because of the pandemic, and what you've had to adapt or change or learn to do differently. So Tab, will have you take this one.
Yeah, well, the one thing I want to relate to everybody is that if we look across Montana, generally speaking, we can say that I'm not sure we've lost a student in Montana to COVID, but I do know that we've lost numerous students in the span of COVID to suicide. And so, for us, maintaining the perspective around, we're putting a tremendous amount of time, effort, and person power into the COVID effort, COVID prevention, and screening, and contact tracing, and doing all those kinds of things. And it's taking a lot of our people's time, including our nurses. But the conversations I've had with our nurses are around, we know that that's essential work we have to do, and yet really making sure that we're screening as many students as we can with our merit screener is probably going to, in the end, be more life-saving and more impactful. So we just, I guess what we haven't done is lost focus on getting our social and emotional screening project going and functioning well. But COVID caused a lot of delay. We've had days where we'd have a couple of COVID positive cases in the schools, and the nurses would spend their entire day on contact tracing and wouldn't be able to run the SEL screener. But we've just persevered, and we've continued to reschedule and spread things out as we needed to, and plod along and get it done. We did develop a plan to, if we weren't going to be on site at all, to be able to implement the screening remotely. And because it's an electronic patient-reported outcome survey, this is something that students could take remotely from home, from a cell phone or a computer. We still do have that option. We have some students who are fully online. We haven't tried that out yet, but we will probably in the coming weeks have a couple of students who are fully online students take the survey from home. But I think really the main thing is just coming back around to trying to keep our perspective around what the threats are to kids and where we need to apply our efforts. And this is certainly one of the areas where we feel like we need to make sure we get it done.
Thanks. There's a lot of agreement to your statement in the chat about comparing COVID and the efforts we're putting around screening on COVID versus the efforts on screening on suicide. So a lot of agreement. And I'd love to encourage everyone to put questions in the Q&A box as we're getting ready to wrap up this part of our presentation and move into the Q&A. So we'd love to hear what questions you have for Todd and Joni. So last question, what are some recommendations you would make for schools who are just starting out or in the initial phase of utilizing the screening module for the school mental health curriculum? So again, we'll start with Todd and then we'll have Joni answer. Yeah,
well, I just reiterate, again, start small and carry a big committee. You know, starting with just a few, and little pilot projects that grow gradually to something bigger, and just trying to win little and win often. That was excellent advice that I got from Jill, and we have followed it, and it's been very helpful. And just having, I have a core committee that's about 15 people, but we have really a large stakeholder committee of something on the order of 50 people statewide who are working with us on this project. And that really helps because you have a lot of people out there talking to other colleagues and families and making this seem like something that's mainstream and something to do. And just move slowly, move a little, and then reflect and revise and move again. And I think that's always good advice in implementing anything new, but especially important with this work. Follow those steps of the curriculum. And it was really helpful for our committee to watch that virtual learning session for Module 4 and study the examples that were in that session. There were a couple of really great pieces of advice that we got from districts that are featured in that. Don't be afraid to look for resources in the community or reach out to people that have been through development of a screening program. I'll put my hand up as one who's happy to share, but I was surprised how many people I was able to find within our community who had some fairly deep experience in the realm of social and emotional well-being, screening, suicidality, and those folks have just been fantastic partners in this work. One small thing I would urge considering would be using DocuSign or a similar electronic signing service for your consent or assent forms. These days, it's getting hard to get back paper consent forms, it seems like. And we felt like we had a pretty good response to sending these out via DocuSign. So I would suggest that. If in your state there's a state team that you can be a part of, that has been so helpful to me to be a member of this Montana Student Wellness Advisory Committee, because it seems like there's a person like me in every community in Montana who's trying to do the same kind of work. And then as you prepare your communications to your community, I would strongly suggest vetting them with your whole team. For me, that included taking my press releases and my parent letters to our school board, to our school administrators, and to all members of our local committee and our statewide committee. And really, I had the stamp of approval of all those folks before I went ahead and hit the send button and sent it to our local newspaper and sent those communications out to parents. I bet Joni has some really great ideas as well.
Yeah, just a couple, I think, and piggybacking on something you said earlier was like starting small. And I would add to that is start small with existing systems that you have in place. So don't make a new committee that's dedicated just to screening. I think my experience is that further stigmatizes the issue. It's like highlights to people that this is something new that they should possibly be concerned about. But if it's integrated into existing school advisory committee or school wellness committee, then I think it sends a message that this is typical practice that we're integrating with all the other screenings that we do, and that we care about this whole child approach. It doesn't isolate it. I would say the same thing at the school building levels. Like once you start implementing screening, don't make a new team. Have a district that created a whole new team just for screening data when they already had a problem-solving team that was used to looking at discipline data and academic data and lots of other data. They already had that, so they could have integrated the screening data into that and not created a new team. That really created a lot of angst amongst their school personnel who didn't really want another team meeting to attend. And then the other short, real brief thing is just, I think Todd said this, but clarifying your goals from the very beginning and using that to drive everything you do, and clarifying your goals with your stakeholders. So if you're having issues of suicidality, then your goals are preventing that, and that's kind of the screening system that you need to implement. If your community is more, if there's a higher concern about pro-social behaviors and social emotional well-being, then that might steer you to a different approach. So that first step is critical. And I think I'll hand it back over. I think we have questions, right?
Thank you both so much. We really appreciate your sharing your experiences with us and your expertise. And I think you shared so many little tidbits that people really appreciated. I know I was jotting down things. So hopefully we all can learn from your experiences. So we do have some questions that have been coming in. We encourage you to continue adding those as we move into our Q&A. And I'm excited to pass it off to my colleague, PG Wenger, who is a school mental health lead at Region 2 MHTTC, who has been monitoring the chat box. And so I'm going to pass it over to you now, PJ.
Thank you, Stephanie. So we have a couple questions. The first one is a two-part question, so I'm going to give it to you in parts. As you mentioned, individual screening, would you comment on two questions? So the first question is, what do you have to individually screen elementary students for suicidality, 4th and 5th grade? That's the first part. The second part is, some districts are reluctant to allow their counselors to say suicidality is low to high risk using the Columbia Suicide Scale. What are your thoughts on addressing this?
So I was looking at that one earlier and trying to think. I can't think of a tool off the top of my head that I know for sure is normed for 4th and 5th grade. Jill, that might be one better to email me and let me look at a couple of resources before I answer at the top of my head. Is that okay?
Sure.
And I'm happy to do a little digging right now. So okay. I'll do a little research on, so the SHAPE system has a whole library where you can search tools, theshapesystem.com, but I'll also just go there now and check it out while Todd and other folks are answering this and other questions.
Well, I love that question because we don't have a screener that we've identified for 4th and 5th grade, and yet we understand that, only to a certain extent can you use depression and anxiety as sort of proxy screeners for suicidality. You actually have to be able to ask the direct questions about suicidality. So I'm also interested in that answer.
So the second part of that question was, some districts are reluctant to allow their counselors to say suicidality is low to high risk using the Columbia Suicide Scale. What are your thoughts in addressing that?
I'm also going to default to Todd on that one.
Well, so the person that I know who knows the most about this is Dr. John Greist. He and his team have done extensive work with the people who created the Columbia Suicide Severity Rating Scale to create this ePro version of it. And, in everything that he has presented to us, and some pretty strong research suggests that the Columbia is very accurate with respect to those risk levels. And so we are doing our triage in that way. So a strong positive is getting, immediate help from the crisis response team, but the softer positives are, they're being referred within days to, to other help.
Okay, so another question is, can you speak to the difference between an SEL screener and a mental health screener, or are we using these synonymously?
That is a great question. It kind of makes me think of a Venn diagram. So I definitely think that there's overlap, and we're using in some parts of them synonymously, but there are also probably unique differences. So when I use, and most of the literature thinks mental health screening, we're really thinking about mental health risk around like internalizing problems, depression, anxiety specifically, and predictive validity for that, and externalizing problems like conduct and opposition behavior, antisocial behaviors, those kind of disruption, impulsivity, those things more of like symptomology you would find in the DSM. Whereas social emotional might be more aligned with like CASEL, collaborative academic social emotional learning competencies, right? Around like self-regulation, self-management. Typically an SEL screener, also most of them have like a pro-social domain, or also have some sort of peer problems domain. And so there's a lot of like shared variance amongst those different kind of constructs or behaviors, right? And we see a lot of overlap, and then self-regulation might be low for a student who's also low with impulsivity, right? And we see a connection there. It's just, I think a lot of districts who really do not view themselves as in a mental health role or don't have a ton of mental health resources feel better, to be quite honest, about a social emotional screener with some pro-social behaviors, that is in their domain. There's a direct connection of those skills to academic performance, and so it is more in their lane and more acceptable to their community.
Well, that's excellent. Learning a ton from you, Joni. In our school system, you know, I've oversimplified this thing, but what we've tried to do is we've used social and emotional maybe a little bit euphemistically, so that we're not saying we're screening for suicidality. That's a harsher thing for the community to hear than that we're screening for, you know, social and emotional. But really what we've tried to get in the habit of is talking about all of it as just a health screener. You know, mental health is health in our view. And so we're trying to say, whenever we can remember to, that this is a new health screener versus that it's either mental health screener or social emotional learning screener.
Okay, another question that popped up in the chat box is, how often should we be screening for suicide?
So I don't know that there is empirical evidence to support any of screening frequency. I'm not sure, Todd, what is your screening schedule look like? I don't think you ever shared.
Yeah, Joni, that's what we found too. What we have tried to do, rather than say how frequently, is to have some target times. So we know from our data that October and February are typically our most difficult months for suicidality. And so we're trying to screen in September and January. We've had some delays. We're still screening now because of the COVID delays, but in an ideal year, we would screen in September and January.
And I love how you use some of your existing data. That was kind of something, Jill, you talked about, right? And previewing the modules of like how you can use some existing data to help you kind of narrow down your targets and think about like how you're going to plan your screening approach. In the domain of more like social emotional screeners and mental health screeners, the general recommendation is twice a year. I've seen some that suggest 3 times a year. I think it depends on, in a younger population, you probably only need two times a year because you're just not going to have as much new elevated risk. The risk is fairly stable. In middle school, we start seeing it become less stable. So you might want to do 3 times a year. But I definitely suggest that like at least twice, because if nothing else, that second time point can give you kind of a post-test evaluation. That gives you data to plan for your next school year, to align your resources, do that program planning. I've had districts use that last time point to leverage for grant applications or other resources in their community with United Way and the like.
So we have one more question in the Q&A, and I think it's more asking your thoughts on this. Is screening is definitely a hot topic in legislation right now. As an LCSW, I am biased. However, when we discuss the various risk levels on the Columbia, it simply speaks to why the screening ought to be done by a trained and perhaps more importantly, an experienced mental health professional. Any thoughts?
I definitely think when we're talking about suicidality, if that's what we're screening for, absolutely. You know, I think that's part of the value of where Todd has said they put it in with school nurses, is that it provides that immediate connection to a mental health professional and can follow up, and it puts them in their domain where they've been trained to address it. I think when we're talking more social emotional screeners and broader screeners, then you know, we can have a more generalist kind of approach to collecting the data, with making sure that there's mental health professionals on the team interpreting it, that there's mental health professionals reviewing it immediately for any like indicated items that are immediate follow-up, but then that they're also on the team reviewing the entire data.
Yeah, I really like that.
I think I'll
Go ahead, Jill.
Jill. Go ahead, Todd, and I'll follow up after you. Continue.
Just briefly, you know, I appreciate that comment from Noelle and agree. You know, what we knew was that we didn't have the person power to do the to do the Columbia with every single student in grades 6 through 12, but we wanted that level of specificity. So by using the electronic version and then having our school nurses, but also we have a clinical psychologist who is co-located in our high school. And that person, if there is a diagnosis to be made, that's the person who's going to, you know, dig deeper and use that data to make that diagnosis. So that was an important point. Thank you.
I was going to say a similar thing, that, you know, it's really part of that follow-up process. And we've seen districts who, you know, have this happening across a free period for students where they have teachers who are administering or proctoring, but what happens is there's a script that everyone reads, and then there is a you know, very coordinated follow-up process. So if a student asks a question, if there are these, you know, types of risk indicators that a teacher observes, you know, these are the people who are on call to come and to support that. And so that's allowed them to expand their capacity and to make sure that the mental health staff are doing just that, you know, that they are the ones who are there to make sure that they're identifying any of those, you know, those risk factors. And while I have the mic, I'll follow up and just say I did some more digging, and I saw we had some more conversation in the chat about the specific screeners for suicidality in elementary students, and agree that there is not a ton that's specifically for that group, but that as Todd had mentioned, that those depression screeners that do have some specific questions, specifically the PHQ-9 is normed across ages and has some specific questions about suicidality as a you know, a first step in a screening process to look at suicidality for that age group. And great, it looks like Connie threw in an additional resource there, and it's critical to, you know, as I think Todd mentioned, to be leaning on this community of folks who are dedicated to this work, and as everyone added, you know, just really highlighted this work of saving lives.